Okay, so this lady is a Gravida 2 Para 1. She had an SVD previously in 2020, and unfortunately, the baby had meconium aspiration at this delivery. Was admitted for I think a period of about 5 to 7 days. Baby was quite poorly, but recovered really well afterwards. Her medical history: she has gastritis. Previously, a herniated disc, so she was seen by our anaesthetic team, and her BMI was 23 at booking. At 24 weeks, she came in with query SHROM and some reduced fetal movements, but there was nil concerns. At 27+6, she had some really swollen legs, so leg Dopplers were booked and she was being seen in DOU. All of the investigations were normal, however. And then at 35+5, she had some itching on her hands and feet, so some obstetric cholestasis bloods were taken, and they were all normal. Bile acids were perfectly within range, as were her ALTs. And then at 40+6, she came in with SHROM. SHROM was confirmed, and she was sent home on our SHROM protocol. I don't have that CTG, unfortunately, but I know that her baseline was 140. She had accelerations on the CTG, no decels, variability was within normal range, and overall the CTG was normal. And at this point, she was contracting. Something that I wanted to discuss, which went out as a key message for this case in particular, was when we're giving information to women, RE, our SHROM protocol, we send them home. We say, avoid intercourse and check your temperature every 4 hours. And if there's any concerns, RE, your well-being, please call us back or come in to be reviewed, essentially. She actually was a low-risk woman, so she didn't even need a CTG when she came in with SHROM. She could have been sort of intermittently auscultated, but that was obviously the decision that was made by the team that came on. So we always tell our women to check their temperatures every 4 hours and then come in at 24 hours. So she came in on the 25th of the month, so she's 41+0. I think her waters broke at in the afternoon, early afternoon of the 24th. So she didn't come, she came in, no, apologies, my mistake. Her waters broke when she was 40, Jesus Christ, 40+6 on the 24th of the month at 4 o'clock in the morning. So she returned to triage at 4:15 on the day of the 25th of the month. On her initial fetal heart rate, it was 67 beats per minute on auscultation. So she was immediately put onto a CTG. At 4:25 in the morning, she was examined and found to be 2 centimeters dilated, and her maternal pulse at this point was 118. Her respiratory rate was supposedly normal at this point. Her oxygen level was fine. Her blood pressure was on the lower side. I believe it was about 101/58, which was slightly lower than her booking blood pressure, which I believe was about 120/80. And she looked and appeared incredibly unwell. So just looking at this off the base of it, what do we think could be the initial reason why our CTG has gone from a baseline of 140 to a baseline of 160?
Hi, looking at the maternal pulse, it's also raised, so there could be some infection brewing.
Yeah, absolutely. Although we've got good variability on this CTG, which is obviously a good sign for the neurology of the baby, we do have a significant rise in baseline. But what I wanted to sort of discuss, because this is on the shorter case sort of side, what I wanted to talk about is when we have a patient that comes in with a maternal pulse rise and a fetal heart rate rise as well, we kind of use those two things to kind of identify what the situation is happening. So if we've had a baby that's had a notable rise in baseline initially, and that becomes first, our initial sort of thought process might be, okay, this is more likely to be choreo. Whereas when we have a woman that starts to deteriorate, so her heart rate goes up before the baby's does, then we tend to sort of get the impression of, you know, of maternal infection as opposed to sort of starting off with the baby. So my question is, how do we differentiate the two when they come in and they're both raised? And also, what are we going to do about this? What's our plan of action?
Would you do a septic screen?
Yeah, you can do. So when it comes to maternal observations, we initially think, okay, if we're going to do a septic screen, there's this common thought process of, okay, we have to have a woman with a temperature of over 38 or two temperatures of over 37.5, which is an hour apart. But actually, we can take the maternal pulse as an indication to do a septic screen. Not only that, but we've also got a mother that's unwell, that's also affected the baby that's unwell as well. So actually, that's enough of a clinical indication to do a septic screen. Anything else anybody wants to add to the plan of care?
I just wonder, considering what you've got here, and you always think at the start of a labour, or when you're first doing this initial assessment, asking a question whether this baby is fit for labour. You're right that the variability is normal, and that is at least one good reassuring feature. But you've clearly here got signs of chorioamnionitis, a baseline that's not normal for gestation, plus a significant rise from previous. You've got to ask, do we think there's a possible sign of chronic hypoxia here? And is labour the right thing for this baby? I'm not entirely sure. I don't think so.
Yeah, absolutely. She's 2 centimeters, so she has been having some contractions, and you can see them quite clearly on the CTG as well. So it looks from that she's contracting 4 in 10. Unfortunately, there wasn't anything that was mentioned in particular to her contractions at this time. But what I do know is she was definitely feeling them, because it was reported that she was contracting. Whether or not they were strong or regular or anything like that wasn't really documented. But she was contracting sort of 3 to 4 in 10 that was written on the BSOTS note. So bear in mind, she's still in triage as well. So if we're thinking about the overall clinical picture, we've got a lady that's now prom. She's clearly had a decline in her own way, so has the baby at this point as well. And we're 24 hours now. So taking all of that into consideration, we're probably going to do a septic screen. We're probably going to give some antibiotics. Would anybody be happy that if we gave these kinds of medications, that then we could maybe wait for it to settle? Is anybody thinking, okay, I want to deliver this woman? Like, what's everyone's thought processes? Okay.
Maybe just wait a bit and just to see how her body reacts, and then reassess. Maybe give it an hour.
Yeah, we absolutely can do. So, my PowerPoint's decided to. So she remains in triage. And this is what happens next. The emergency bell is pulled at 0440. So the registrar, the SHO, and the midwife in charge come in. She's cannulated. At 4:52, the plan was made to cannulate her. At 4:52, a cannula is inserted, and another deceleration is heard. And what you can see that looks like a possible decel is almost certainly a decel. So she's put into left lateral position. At 5 in the morning, the obstetric registrar was out of the room at this point, has actually come back in. At 5:14 in the morning, the midwife in charge has left the room and has come back. And then at 05:15, she started vomiting very much. And I think IV fluids and IV antibiotics were started at around 5:20 in the morning. I believe bloods were taken when she was cannulated and possibly septic screen, but I don't think blood cultures were taken, which, just as a sort of side note, is a 100% part of our septic screen. So you need to take blood cultures, which are the bottles that I think have, one's purple and one's got a green top now because one of them's changed colour. So plan, anyone want to add anything?
Looking at the TOCO activity, it seems like it's an irritable uterus. There's, I feel like there's no resting tone there.
So what would you do, Darshni?
Tocolize?
Yeah. If you're concerned that you've got hyperstimulation and that's also having an impact on the CTG, and you've both got an unwell baby and an unwell mother.
Deliver?
Yeah. Do we have any obstetricians on the call?
Sorry, I joined late and only via phone, so I didn't get the story. I do not know if she's primiparous or multiparous or how far she actually is. I only heard P-prom.
So she is prom. She is a Gravida 2 Para 1 previous SVD with meconium aspiration in 2020. And she was sent home on our SHROM protocol. So she SHROM 24 hours ago at around 4 o'clock in the morning. And she's come back in. This was our initial CTG Dagmar, and then it was obviously continued. And she's 2 centimeters dilated with a maternal pulse of 118, a blood pressure of 101 over, did I say 56? Which is lower than her booking. And oxygen saturations are normal, and so apparently are her respirations.
Right. So we think at the moment this woman is septic and has an irritable uterus or has a choreo probably. Unless you tell me that there are any other kind of signs of infection. So with a choreo and a Para 1 with a previous unwell baby, I would resuscitate the mother because she's the kind of patient that we need to kind of care for in the first instance. And I would have a conversation with her, saying, we might be able to kind of get so antibiotics will not treat choreo. It might keep it at bay. But obviously, if we have the kind of injuries to the baby can be on multiple ways. So hypoxia is one, infection is another, temperature is again another, and she will have had her own experiences regarding meconium because that is sooner or later likely to follow. And then you would have a conversation about would she like to continue, and or would she be happy to get the resuscitation and a repeat VE, because she would not be one where I would like to start Synto on. So either all of this uterine activity gets her into labor whilst we resuscitate her, or I would be happily offering her to bail out.
Perfect. Thank you, Dagmar. So 0520, she's given, go on.
Sorry, can I just ask a question?
Of
If
course
she's
you can.
vomiting, will that affect the uterine contractions? Will it appear more?
Yeah, probably, because of the way that the TOCO is, and because it's picking up uterine activity. Obviously, when you vomit, your stomach does tend to tense, and that will probably be picked up on the TOCO. But obviously, the only way that you can actually feel contractions properly and see them properly is if you were to palpate them yourself. In this case, I think where she started vomiting at sort of 5:15 in the morning, as you can see, it looks like she's got a 5-minute long contraction. But she probably doesn't. But obviously, because the TOCO is where it is and where it's so close to the abdomen, that it's going to have that effect, definitely. Well, almost certainly.
Thank you.
Perfect. So she's given some IV fluids. So bear in mind as well, guys, our baseline here is 180. And she's also, previous baseline was 140. So this is a massive, massive jump. We've also, in my opinion here, we've gone from having obviously a rise in baseline. We've now got chemoreceptor decelerations. These are sort of prolonged as well, although there is good variability to an extent within them. And we've now got an even further rise in baseline, and we're starting as well to lose the variability here. It's significantly reduced to that one previously. Can anyone sort of give me an idea of what type of hypoxia that might be?
Gradually evolving.
Yeah, absolutely. Absolutely. She goes out to the toilet at 5:30 in the morning. I don't believe that urine was dipped, but I think it was dipped initially. 5:35, she's vomiting again. So she's given some cyclizine, which is intramuscularly. And then at 5:45 in the morning, the registrar. So bear in mind, this woman is still in triage as well. The registrar comes back into the room, re-examines this woman and says she's 2 centimeters dilated and that we need to have an emergency cesarean section. Now, I couldn't tell you exactly how, I'm sure there'll be somebody that will be able to tell me this. I couldn't tell you exactly how quickly after antibiotics you should start to see the effects of it, because I'm pretty sure it happens differently in every single patient and depends on the sort of location of infection. But considering by the end of this CTG, it's actually been 40 minutes since the start of it as well, we've still got nothing that's showing us signs that this baby is happy, and nor is the mother. Dagmar, have you got any of your research behind that at all?
No, but I'm still remembering. I still have all of the kind of other stuff to send you. I did that, but here it's essentially just well, I mean, consider the odds. What are the likelihoods of this kind of woman having a normal vaginal birth? I mean, just ask yourself. So if she's 2 centimeters now with all the uterine activity that she has, the answer is not very high, no? Right, because it's very often with choreo that these just seem to go, and and then you're playing for time and you're using toco and you're using antibiotics and you might essentially kind of get there. But I wouldn't even dream about doing that because I can't see any stabilization. I still see the kind of now more shallow looking decelerations and I see no variability anymore. So what am I trying? So I'm with that. So I would happily offer her a cesarean section. Yeah. I wouldn't be doing anything differently. Neither would I wait.
Perfect, thank you. Oh, I don't have a theatre CTG because I don't believe one was put on. This is something else I wanted to seriously highlight with this case. When we have a baby that's clearly unwell, when we move to theatre, specifically as well, if they're having any kind of spinal anesthetic, we need to know how well that baby is afterwards, okay? So please, if you're ever taking a patient to theatre that's previously been on a CTG, and specifically as well if it's been abnormal, we need to make sure that we're putting the CTG back on in theatre. Babies, as we know, can have quite a significant bradycardia following a spinal spinal anesthetic, and not that that would change the sort of timing of this delivery, but it may adjust to be a lot quicker. And bear in mind, with an acute hypoxia like that, like a bradycardia, your pH drops 0.01 every single minute that it's in that. So if that means the difference of a minute from the or maybe the obstetrician scrubbing a little bit quicker to get in and start delivering quicker, that's actually quite vital time. As well, we've got an abnormal CTG prior to this, so it means we've probably got a baby whose pH is dropping already, and it could then be affected even more so if that's the case. So this CTG finished at 6:05 in the morning. Does anybody want to guess the APGARs or the gases for this baby and what the outcome might be? Because she was then taken to theatre.
Definitely, well, not, I shouldn't say definitely, knowing my luck, but probably a really quite high lactate level, possibly a normal pH. You just about maybe are at 5 for your variability, maybe.
Thanks, Katie. Anybody else want to have a guess? No, everyone's being shy. Okay. This baby was born with APGARs of 9, 10, and 10. I should have mentioned the fact that this baby was born at, I think it was 6:31 in the morning, I believe. So about 20 minutes after that CTG was finished, or 25 minutes. Venous pH was 7.2, basic cess minus 7.6, and a lactate of 7.5. Arterial pH is 7.18, basic cess of minus 9.6, and a lactate of 9.5. So quite a high lactate for a neonate. We'd like it to be less than sort of 6, and ideally less than 4, 3. This was a query choreo case, which was identified at delivery. Just sometimes, there is a distinctive smell quite a lot of the time when you have a choreo case. This baby didn't require any inflation or ventilation breaths, but had to have some oxygen support at delivery and was transferred to our neonatal unit. It's worth noting that the neonatal temperature was 38.1 at delivery, so this baby was quite literally cooking on the inside. I don't know whether this would have had much of a difference, but maybe if we'd have given some IV paracetamol to the patient as well, that may have had an impact on the mother, which may or may not have passed through the placenta. But if you've got a woman that's got a temperature, think about the fact that your baby can have from a degree or 0.5 to a degree hotter in utero. So if you've got a woman with a actually it's 0.5 to 1.5. So if you have a woman with a temperature of 37, that baby could have a temperature of up to 38.5. So it's quite a significant difference, which is why we're even more anal about it when it comes to our septic screens and whatnot, and making sure we're getting the right medication on board. But yeah, this baby was very, very hot at delivery, which is quite common with chorioamnionitis. Does anybody have any questions? And this baby was also on the 91st to 98th centile as per the WHO guidance, because the gap chart wasn't unfortunately done, and weighed 4.35 kilos.
Is the baby okay now?
Yeah, baby recovered well, was given 5 days of antibiotics, and is now very good.
Do you really think that there was any other way but going for a cesarean section in this case?
I don't know. I don't. Pause. No. I think that they made the right decision here. I think the only things that I would have done, if with the benefit of hindsight, I definitely would have given some IV paracetamol, just to sort of help the mother as well. And I probably would have actually put a bit more of a rush on it, because I know that there was sort of umming and ahhing for a little bit about whether or not to resuscitate the mum and try and see if this was going to settle down before going to theatre. That's just the impression I got from the notes, but it's purely a possibility. But I would have moved a bit quicker if this was me. Not that that would have made much of a difference, I don't think. But I would have said after that second sort of prolonged looking deceleration, that would have been the time to call for the emergency cesarean section and get her around to theatre. Because from the time she came in, it was actually 2 and a bit hours later till the baby was born. And because of the fact that we went from having normal variability to then reduced variability in this sort of 40 to 50 minutes, I think if we'd have maybe timed it a little bit sooner, then that may have had an impact. But also at the same time, obviously, we hadn't given the woman any fluids, any IV antibiotics at that point, although they could have been done in theatre.
It always depends. So I think this is then the difference between notes telling the story or you physically being there, because obviously, by the time observations look really dreadful, fair enough. But there is something to clinical expertise, i.e., looking at someone, and if or kind of being with someone, and if somebody's really unwell. Do you then sit on a CTG like this? Do you think it's easy to resuscitate? Because I mean, choreo, we always have to kind of think it's a mixed ball of kind of bacteria that can do that, no? And then there are some that are well reached by our antibiotics and some are not at all, particularly with increasing resistances. And only some of our antibiotics ever kind of cross the placenta in sufficient amounts. So I mean, if you have a kind of heart rate of 180 and hyperstimulation and it's a para 1 and you're at 2, I honestly can count the numbers of times where that had a happy ending on my hand. And sometimes I thought we were getting away very lucky. So I have a lower threshold to go for section with choreo. But that speaks for my bad experience maybe also, because we all have ours.
Yeah, I think we're trying really hard at the moment to try and consider choreo in a few more of our sort of like clinical situations, because I think it's not something that before I started the job as a fetal wellbeing midwife, it's not something that I'm particularly familiar with. I'm going to be completely honest. And then since I started in the role over a year ago, it's been a case of, okay, we actually, a lot of our cases are chorioamnionitis and we haven't just identified it because it's not something that we've necessarily considered. Because I think a lot of the time you see a rise in baseline, if it then has an impact on the mother, you just automatically think of sepsis as opposed to anything else. So I think we're working in the right direction to kind of change that culture in our unit particularly. We're talking about it a lot more, which is really positive. But yeah, I think that was definitely considered in this case. Perfect. If nobody has any more questions, that's us done for the evening.
Thank you, and I will email you the files, Cara.
Thank you, Dagmar.
Thank you.
Thanks, everyone.
Thanks, Cara.
Thank you.
Thank you, Sarah.